se posadili a začneme s první částí odborného programu dnešního dopoledne, který se týká osteoartrózy a máme první dva řečníky ze zahraničí. Já bych uvedl první, kterou je paní profesorka Johann Martel Pelletier. Paní profesorka je profesorkou medicíny v Department of Medicine a je také členkou toho oddělení farmakologie, je i chair in osteoarthritis v Univerzitě Montrealu a ředitelkou výzkumného oddělení na Univerzitě v Montrealu, v Quebecu, v Kanadě. Skoro celý život se věnuje osteoartróze z různých hledisek. Já když jsem teď s ní mluvil, tak mi říkala, že začínala taky revmatoidní artritidou, takže jsem mi rovnou říkal, že tenhle týden vyšel článek Annals of Rheumatic Diseases, který ukazuje efekt metotrexátu u gonartrózy, u takové té zánětlivější formy gonartrózy, velmi rapidní a velmi významný. Takže ta revmatoidní artritida a artróza v některých aspektech nemají od sebe zas až tak daleko. Paní profesorka bude mluvit o budoucích perspektivách v léčbě osteoartrózy. So after the introduction in Czech, I would like to invite Professor Johann Martel Pelletier to give us her lecture on future therapeutic perspectives and treatment in osteoarthritis.
Thank you very much. I first would like to wish Karel all the good things for his anniversary and also to thank the organizer for inviting me to give a lecture on osteoarthritis, the future therapeutic perspective and treatment. So during this lecture, I will review the new concepts that have emerged in recent years and have permitted, at least for the symptom, the development of new therapeutic approaches. With regard to disease-modifying osteoarthritis drug, also named DMOD, important progress made in understanding the pathophysiology of this disease, as well as the identification of the risk factor, have guided DMOD development program toward promising therapeutic target. I will review the potential DMOD, discriminating them according to the joint tissue. Of note, target and drugs that will be discussed during this presentation are by no means comprehensive, but I will try to cover the ongoing and forthgoing therapeutic strategy and drugs. So, pain is the main reason for presentation of OA patients to clinics. The current pharmacological management of OA is based primarily on the use of analgesic, NSAID, and anti-COX-2. Although studies have confirmed the efficacy of NSAID and anti-COX-2 as symptomatic treatment of OA, none has proven to affect positively the natural course of OA in humans. Importantly, some of the treatments that address disease symptoms, such as NSAID and narcotic, have been found to cause significant side effects which are concerned with the aging population. Likewise, the acetaminophen, the first-line agent recommended by most practice guidelines, has also potentially toxicity. Consequently, authorities now recommend that it be taken with caution. Indeed, side effects associated with acetaminophen has demonstrated some gastrointestinal problem and also renal failure. For NSAID and even for some COX-2, they also showed GI and cardiovascular events. But if those two classes of drug are discarded, we will be left with narcotic or opioid, which have even a higher risk than NSAID and COX-2. And as represented in this slide, in the red line, opioids are associated with increasing the risk of cardiovascular, fracture, safety events, as well as a higher mortality rate. Also frequently used for symptom relief or intra-articular injection of corticoid, hyaluronic acid, and topical analgesic or NSAID, for which many studies have demonstrated their efficacy and safety. There are also the Cysadoa, in which for some efficacy and mostly safety were demonstrated. However, more subjects with OA will continue to experience pain. Hence, drug therapy for musculoskeletal pain is changing, and most of the current research in osteoarthritis pain arises from a broader pain research effort, with some of the drug developers proposing drugs from other indications to osteoarthritis. In this context, in recent years, antidepressants have been introduced for osteoarthritis pain management, and one of the drugs, the duloxetine, a serotonin norepinephrine reuptake inhibitor, has demonstrated analgesic property, and interestingly, in osteoarthritis knee pain, the analgesic effect was not related to an action on the depressive symptom. This drug is on the market in some countries. At present, there are other pain-related agents under study belonging to the different class, and one of them is the anti-nerve growth factor, or NGF, the inhibition of which reduces pain and hyperalgesia. Although a phase 2 study on osteoarthritis showed that tanezumab was associated with pain improvement, these results in terms of efficacy were challenged by the neurological side effects seen in all the studies performed with tanezumab. However, after examining the dossier, the FDA in USA agreed to let the company resume their clinical trial with their respective NGF inhibitors. Other compounds or drugs are the bradykinin B2 antagonist, the botulinum toxin type A, the cannabinoid receptor A2 agonist, and the FAAH. For the FAAH, a study was stopped because of the lack of analgesic effect. The chemokine receptor 2 antagonist, and a phase 3 trial was carried out with a plant extract which affect the CCR2 and reveal a reduction of pain. The antagonist of the histamine H3 receptor, the kainate receptor, the P2X7 receptor, antagonist and agonist of the vanilloid receptor, TRPV1, and presently one of the drugs, the Sivamid cream, received a compliance in Canada. So, however, the ultimate vision for the treatment of osteoarthritis have been to find agents that can reduce or stop the progression of the disease. Thus far, no such treatment have been approved by the regulatory authorities as meeting the appropriate guideline and criteria. However, as you will hear during my presentation, one such drug could be submitted to the regulatory authorities. So osteoarthritis could be described as alteration in at least 3 tissues, the cartilage, synovial membrane, and subchondral bone, leading in this tissue to a degradation of the matrix, and if nothing is done, to the joint replacement. Therefore, it is a need for agents that will stop or arrest this degradative process. At the articular level, osteoarthritis is characterized by a degeneration of the articular cartilage. Moreover, a complex relationship also exists between the subchondral bone and cartilage, in which during the OA process there is a remodeling of the subchondral bone. The subchondral bone plate is located at the base of the articular cartilage, and in normal, subchondral bone is thin and acts as a shock absorber, and it protects the articular cartilage against damage caused by excessive load. Evidence thus suggests that alteration in this tissue, the subchondral bone, are currently seen as a major pathophysiological factor in the progression of osteoarthritis. However, we don't know yet if alteration in this tissue take place before or after cartilage degeneration. Nevertheless, at a certain point, both cartilage and remodeling of the subchondral bone take place. At the clinical stage of the disease, these alterations are accompanied by change in the synovial membrane, where an inflammation reaction is often seen. Although we do not completely understand what initiates the degradation of the articular tissue, the morphological change in osteoarthritis are found to be related to a complex network of biochemical factors which lead to the breakdown of macromolecules in the articular tissue. Importantly, data demonstrated that there is a movement of factor and cytokine from the different joint tissue to the cartilage. There is now evidence of a global crosstalk among this tissue, the cartilage, subchondral bone, and synovial membrane. For the structure-modifying osteoarthritis drug, where are we today? To date, only few agents, including chondroitin and glucosamine sulfate, diacyrine, piasclidine, and doxycycline, have demonstrated several interesting properties, including an extremely low incidence of side effects. It was also found by using X-ray that chondroitin, glucosamine, piasclidine, and doxycycline reduce the joint space narrowing in knee osteoarthritis and diacyrine in hip osteoarthritis. Recently, our group, and that will be discussed by Professor Pelletier, showed that in a pilot study using the magnetic resonance imaging that chondroitin sulfate decreased cartilage volume loss in knee osteoarthritis patients. However, by using another cohort, the Osteoarthritis Initiative cohort done by the NIH in USA, and MRI, a decrease of the cartilage volume loss in knee osteoarthritis was also found with a combination of glucosamine and chondroitin sulfate. So at a molecular level, what will be the best factor to target in the cartilage? Since the first macromolecule altered in osteoarthritis are the collagen and the aggrecan, the first rational approach was to design a D mode and develop strategy to reduce the metalloproteinases level and or activity in arthritic joint. A number of synthetic MMP has already been tested in clinical trial, and data have shown that the broad MMP range produce musculoskeletal side effect. This was suggested to be due to the low selectivity of the MMP. Drug development is now examining the use of more selective or selective inhibitor of MMP. Although opinions differ as to the best MMP to target, one option points to stopping the degradation of the collagen network. In that regard, one of the main candidates is the MMP13, as above all, this enzyme is generally not present in normal tissue. However, it is also suggested that reducing the aggregate degradation will halt cartilage degradation. Presently, there is a phase 2 study on an inhibitor of both ADAMTS4 and 5. There were also other drugs that were studied, and there has been a phase 2-3 study looking with an inhibitor of the inducible nitric oxide. A report of the study revealed an improved joint space narrowing in the mild osteoarthritis at 1 year, but not at 2 years. And importantly, there were no effect in the moderate severe osteoarthritis. In parallel to the degradative activity in cartilage during osteoarthritis, researchers have also devoted effort to identifying conditions that are favorable to our formation of a durable and functional cartilage surface. This has led to the study of 2 such growth factors, the BMP7, or also named OP1, and one of the members of the FGF, the FGF18. Those two drugs are presently in phase 2B in patients with knee osteoarthritis. Another innovative biological approach related to the platelet-rich plasma, or also named PRP. The rationale for using PRP is that platelets contain a storage pool of growth factor, including, among others, TGF-beta, VEGF, PDGF, as well as cytokine, chemokine, and other plasmatic proteins such as fibrinogen, which are currently thought to accelerate the natural healing process and promote cartilage repair. Intraarticular injection of PRP are studied in cartilage in phase 2 and 3 presently, and there is, in addition of pain, they're looking at the healing and regeneration of the cartilage. The data up to now show that an improved reduced pain and clinical score begin after 6 months of treatment of the PRP. But future will let us know if it's working truly on the, as a demo. Synovial inflammation, as I alluded to, it is well known that at the clinical stage of the disease, there are also changes in the synovial membrane where an inflammation reaction is also seen. What are the evidence? Hence, data from various studies suggest an association between the inflammation and the progression or appearance of structural changes in osteoarthritis. Correlation between inflammatory marker and appearance of the disease have been reported and include the COM, HA, CRP, IL-6, and recently IL-8. And in regard to the clinical study, one of them was performed by our group and showed in vivo that indeed there were a correlation between the severity of the synovitis and the reduction in the cartilage volume loss as determined by magnetic resonance imaging in osteoarthritic patients. Although several soluble mediator and pro-inflammatory cytokine have been identified in osteoarthritis synovium, it is currently believed that IL-1 is the main cytokine involved in this disease, as is TNF, but at a later stage of OA. Different lines of inhibition of IL-1 and TNF-alpha have been and are being investigated as the mode, and these include 4 IL-1 antagonizing IL-1 beta. One of the first to be studied was the IL-1 receptor antagonist, or IL-1RA, which is a competitive inhibitor of the IL-1 at the receptor level, in which by binding to its receptor, it prevents the signal of the IL-1. The IL-1RA have been shown to be not effective for symptoms. However, one must remember that these studies were done using only one injection and look at the symptomatic effect 6 to 12 weeks after. So it is suggested that new study using different strategy for the administration of the drug to maintain a therapeutic level over time should be performed before excluding this line of treatment. Other, which are presently in phase 2, are to have an antibody against the IL-1 itself or the receptor of this cytokine. Moreover, IL-1 beta is synthesized as an inactive precursor and must be activated by an enzyme before being released extracellularly as an active or mature form. A protease named IL-1 beta converting enzyme, or ICE, can specifically generate the mature form of IL-1 beta. A trial targeting the ICE has been performed in rheumatoid arthritis, but has to be stopped for what we believe to be liver toxicity in animals. So we hope that other generation of ICE will come on the market. For TNF-alpha, there have been some case report, pilot trial, but double-blind clinical trial has only recently started in osteoarthritis, and some drugs are in phase 1 to 3. There have been pilot study and investigator-initiated trial on erosive NOA, which for adalimumab and infliximab, which have demonstrated benefic effect of those drugs on erosive NOA. Other factors were also targeted to reduce inflammatory pathway. Among them, there is the phosphodiesterase 4 inhibitor in NOA and 5-lipoxygenase inhibitor in knee osteoarthritis, and both are presently in phase 2 study. If we want to be more general about anti-inflammatory cytokine, there is also inhibition of the pro-inflammatory cytokine-induced signal transduction pathway. Several post-receptor signaling pathways have been implicated in the cytokine's activity, and intracellular cascade provide additional molecular target for pharmacological intervention. In brief, after the cytokine bind to its specific receptor at the cell membrane, multiple phosphorylation-dependent signaling pathways that regulate catabolic and anti-anabolic gene expression are induced. These pathways include the NF-kappa B and the MAP kinase. For the MAP kinase superfamily, it's made up of at least 3 main distinct signaling pathways: the MERK-ER, the SAP-Jun, and the P38 family. So for the signaling pathway, there are some ongoing research, mostly on NF-kappa B and the MAC pathways for osteoarthritis. The subchondral bone is also an interesting articular tissue to be targeted. As I alluded to at the beginning of my talk, emerging evidence suggests that changes in the subchondral bone are closely involved to the disease progression. Data even indicate that subchondral bone alteration may precede cartilage changes. Oops. Could I have the... may precede cartilage changes, and that the subchondral bone play a role in modulating articular cartilage metabolism. So could I have the next slide? I'm sorry, a little... They said no signal. Oui, c'est bon. Okay. So what I was about to say after is that to show you some of the drug that was existing for osteoporotic treatment and then were tried in OA knee osteoarthritis. So I can continue, but they have to fix it. Yeah. Okay. I will restart. So I was about I was telling you that subchondral bone, it's a very important tissue involved in osteoarthritis, and it's maybe one of the most important because data are suggesting that it could for some of the patient, it could precede cartilage degradation. So a potential pharmacological approach is therefore to target a reduction of the abnormal subchondral bone metabolism activity, particularly in the early stage of the disease. With the drug existing for osteoporosis treatment, many agents modulating bone remodeling could be investigated. To date, only few have undergone human clinical trial for osteoarthritis. In this context, anti-resorptive substances such as bisphosphonate, catepsin K, calcitonin, vitamin D, and strontium ranolate would all seem to be well suited against the progression of osteoarthritis. However, for the first 4 drugs, data were very disappointing, but with the bisphosphonate zoledronic, which showed that it could reduce pain and bone marrow lesion. However, this study with zoledronic acid did not look at the cartilage volume. Recent data from a phase 3 study with the strontium ranolate showed conclusive D-mode effect with pain and joint space narrowing. Recently, our group revealed with the MRI that a significant reduction in the cartilage volume loss was reached in some region of the cartilage. We hope that this drug will be submitted to the regulatory authority for a D-mode effect. Other avenues include the implant of the mesenchymal cells and another with gene therapy are presently in phase 2 and 3. The future will tell us if these technology could be used on a large population and for a disease like osteoarthritis and, more importantly, cure this disease. So in conclusion, although there have been some progress in the symptomatic treatment for osteoarthritis, progress has been relatively modest with regard to D-mode. Nevertheless, important progress has been made in understanding the pathophysiology of osteoarthritis and different pathophysiological pathways that lead to the development and progression of the disease have been identified. There are a number of obstacles for the development of D-mode, in which the heterogeneity of OA is one of the most important. This heterogeneity suggests that a single therapeutic agent targeting a single target with a single tissue type may not be sufficient to achieve effective disease modification. As for other diseases, we foresee that we will likely need to consider combination of drugs targeting different hallmarks of OA. However, the future is not so dark as recent emergence of improved technology as magnetic resonance imaging, as Professor Pelletier would describe during this lecture, and also with some of the biomarkers, will provide novel molecular phenotyping of OA patients, which, when combined, will enable improved patient stratification, thus leading to a design and development of personalized OA therapeutic. So thank you for your attention.
Thank you very much for your enlightening lecture, and we have time for 1 or 2 short questions. So maybe I can ask you for the first one. You showed us that there is an increased incidence of fractures in those who take opioids, and it was just quite a strong difference. What do you think is the reason? Is it that the fact that they lose pain and they exercise more, or they have some attention deficit, or could there be some direct effect, actually?
I don't think that. Maybe physician could say it, but I think it's more the dizziness which opioid is increasing. I don't think that it's direct. I didn't see any study in the literature about a direct effect. It's mostly what the drug is doing.
Are there any more questions? So if not, just let me thank you finally for your talk. Give you some.
Po této přednášce mi dovolte, abych uvedl dalšího přednášejícího, profesora Jeana Pierra Pelletieho ze stejného pracoviště, kde